Hello, and welcome to Sarah Clinical Education's Oncology podcast. In this episode, we are joined by pharmacist Dr. Julia Ziegengeist with Atrium Health and Dr. Rodney Hunter with Memorial Hermann Health System. We will be exploring and challenging common assumptions surrounding Adjuvant CDK4/6 inhibitor use in high-risk, HR-positive, HER2-negative early breast cancer. This episode is part of a larger educational program titled Translating Evidence into Practice, Pharmacist-Led Optimization of Adjuvant CDK4/6 Therapy in High-Risk, HR-Positive, HER2-Negative Early Breast Cancer. For more information on our faculty, along with the link to the larger educational program, please visit the show notes for this episode. Thank you all for being here, and I'll go ahead and hand it over to Drs. Ziegengeist and Hunter.
Okay, so wanted to start this robust conversation about CDK4/6 inhibitors and how we really discussed their interchangeability and adjuvant setting of early stage breast cancer, some of the main things between abemaciclib and ribociclib, and how we as practitioners choose these patients and what is the correct eligibility criteria. So I wanted to go ahead and bounce it off to Julia on how you feel about that and what are your thoughts when you encounter these kind of conversations in clinical practice.
Sure. So only 2 of our 3 CDK4/6 inhibitors are approved in this setting. So abemaciclib based on monarchE and NATALEE with ribociclib. And while it could be true that we use kind of this blanket statement that these are both used for high-risk population patients, those risk factors to qualify them for use are very distinctly different. So we as pharmacists can definitely play a role in, determining that eligibility. So to kind of summarize, abemaciclib, if you have 4 or more positive lymph nodes, you qualify, or if it's 1 to 3, you do need an additional risk factor, something like a larger tumor greater than or equal to 5 centimeters or grade 3 disease. Notably, Ki-67 was previously listed in the eligibility criteria, but has since been removed. I know some institutions get those, some don't. With ribociclib, we're looking at stage 2B or stage 3 patients qualifying, or if you're stage 2A with no positive lymph nodes, you do need an additional risk factor, something like grade 3 disease, or if you're grade 2, you need a high genomic profiling criteria, so something like an Oncotype DX or that Ki-67. So obviously, we'll talk about that in more detail when we discuss this together at HOPA, but those are complicated risk factors. And it's important to note that there's kind of no distinction made for this to be like pathologic staging, so pharmacists can also assist in kind of determining by also kind of looking at their clinical staging as well. There's some things that you probably have also seen in practice that make these a little bit more distinct. So obviously abemaciclib, it is dosed at the metastatic breast cancer dosing at 150 milligrams twice daily and was given for 2 years based on the monarchE trial. In contrast, ribociclib is dosed at 400 milligrams. You'll note that that's lower than the metastatic 600 milligram dosing given on that 3-on-1-off setting, also for 3 years, so a little bit longer. Some kind of other distinct things about these trials, they both did utilize invasive disease-free survival as their primary endpoint, with overall survival as secondary. And we also have to keep in mind some of those other things related to the drugs too, right? So ribociclib does require a QTc cutoff in order to qualify for it. And we're also going to be paying close attention to some of those things like drug-drug interactions, because this can act as a CYP3A4 inhibitor.
Yeah, I was just going to chime in as we kind of continue to discuss this place in therapy and really, kind of nailing down this patient population when you start talking about lymph node status and really the fact that when you really look closely into the NATALEE trial, how there were some no negative high risk patients that were included in that trial, which was not identical to the monarchE trial, which was limited to patients who were no positive. So I think that's always a big piece. So when we start talking about how we're evaluating these patients that are going to be chosen for the respective adjuvant treatments. And I also think that there's a big piece of 2 years versus 3 years and patient compliance and how diligent we have to be as clinical pharmacists a lot of times on the teams to stay on those patients to keep them going throughout their treatment for the appropriate duration to get the efficacy that we really would like to see as a clinical team.
Exactly. And your point to the node negative patients is something that's very distinct between the trials. And of course, that limits us in our ability to make any kind of comparisons between the two, because obviously we know if you're lymph node negative, then you're less likely to have a recurrence. So when we're kind of interpreting that data, we definitely can't make any kind of head-to-head comparisons. But certainly kind of following these data as they continue to have longer term readouts, it's something to keep under consideration. I think it's also interesting to kind of note that we're seeing these IDFS curves continuing to diverge over time. So, we have our most updated readout, 7 years for abemaciclib and 5 years for NATALEE. And we're continuing to see those improvements. So I don't know how you frame this to patients. I'd be interested to hear that they're not only having a benefit while they're receiving the drug, but also even after they discontinue it.
Yeah, 100% agree. When patients are starting on the treatments, I always like to actually extract some of the information from the clinical trials, really focused on benefits, so that they can see actual numbers, can see what is the why behind why we're wanting to prescribe this for them in the first place. And I think that's always a great segue to get patient buy-in to actually stay on the treatment and to be diligent. Of course, we'll talk a little bit more about, side effect and adverse effect profile, but great communication between patients and the clinical team in general is always a key to, I think, success when you think about these CDK4/6 inhibitors. If we can get in front of those toxicities, a lot of times we're much more successful at treating them for the entire duration. And I think the placement of, these category 1 recommendations in places like NCCN in this early stage breast cancer space for the CDK4/6 inhibitor, specifically with the ribociclib. And now, you also, of course, we'll talk about the overall survival benefit that you have in that particular patient population with the monarchy. But I think the NCCN guidelines has gotten ahead of a lot of things when it comes to what they would recommend you offer for patients in these clinical scenarios.
Definitely. I think you make a great point related to the fact that both NCC and ASCO have integrated these drugs into their guidelines. And I mentioned the IDFS readouts that have most recently come out, 5 years for NATALEE and 7 years for abemaciclib. And part of that data was also overall survival with abemaciclib, which was an absolute improvement of 1.8%. It was statistically significant, but it's the first time that we've seen an overall survival benefit to either of these drugs. And it is still pending for ribociclib. Given the kind of duration of treatment, that overall survival benefit, the guidelines have reflected that. And we definitely want to keep in mind patients' considerations and specific factors. So if a patient qualifies for both drugs, kind of what are some of the things that you're thinking about, Rodney, in order to kind of determine which one we want to go with?
Yeah, that's a great conversation for us to have. I feel like that's going to be the focus of what we're going to be doing at HOPA as well as here on the podcast. Because when you do have patients that essentially tie from a clinical perspective where they do qualify for both, this is describing my clinical practice. You really start to look at the medications the patient is on currently to assess for drug interactions. I always like to take a look back to see like what did their neoadjuvant and adjuvant treatment looked like in the first place, to see if they really struggle with neutropenia or they were having a lot of gastrointestinal toxicities during the adjuvant or neoadjuvant chemotherapy portion of their treatment. So that's those are like the two places I look at. I want to look at drug interactions. I want to look at tolerability of the previous intravenous chemotherapy that the patient received. And then finally, a lot of insurance companies may have a CDK4/6 inhibitor that's preferred on their list. And if there's going to be financial toxicity or it's going to be very challenging for the patient to receive one of the CDK4/6 inhibitors in the adjuvant setting, and we do have a choice, maybe to have 4 lymph nodes that are positive, have grade 3 disease, then they just fit the high risk profile for monarchy and the Natalie trial, then I will narrow it down to actually looking at what is their insurance coverage to see what is best for the patient financially.
Those are really great points, and also a great segue into our topic of kind of some toxicity management considerations in a lot of other settings in breast cancer. So, for example, with like our aromatase inhibitors, we take the approach where if you don't tolerate one, we can just switch to another. And barring any of those considerations for high risk factors in qualifying for the drugs, is that an approach that you generally take, and why or why not with this class of medications?
Yeah, always careful with these because there are nuances in the adjuvant setting. I think the problem we sometimes have is the way these drugs were approved initially. They were all approved in the metastatic setting, even if you can even include palbociclib in that conversation. But specifically with abemaciclib or ribociclib, there are a lot of similarities when you look at their label FDA-wise in the metastatic setting. So toxicity and switching the patient, and even some of the data we now have with things like post-monarch, there's data showing that you can consecutively use them and still get benefit. But in the adjuvant setting, all of those types of questions have not been answered in reference to shifting CDK4/6 inhibitors in the middle of adjuvant treatment and still maintaining efficacy, maintaining which duration would you go with if you started ribociclib and then needed to switch to abemaciclib. All of those things have not been fully elucidated. So we're always careful to kind of really follow the trial to the letter in the adjuvant setting, unless it is just completely unavoidable. And when we do have those conversations where we do have kind of an unavoidable space that we're in and we do have to switch, it usually is always going to be driven majority of the time by toxicity. And I think that extrapolating some of the toxicities that you saw in the metastatic setting with these two drugs to the adjuvant setting, that is where you see some consistency. So you do have expectations of, they having more gastrointestinal toxicity when you talk about abemaciclib versus having more QTC prolongation when you talk about ribociclib, or when you start talking about the neutropenia profile of both drugs, while both abemaciclib and ribociclib would have some amount of neutropenia depending on the patient treated. If there is a way to address the neutropenia with growth factors, for instance, in those patients who are on ribociclib who have a week break, or if we want to maybe use a strategy of holding a few days of that dose when you talk about abemaciclib in that same type of patient population. Those are like all places to where I feel like we as clinical pharmacists can really interject ourselves when it comes to addressing some of these toxicities, which outside of fatigue are really the top reasons why patients would actually discontinue therapy with ribociclib or abemaciclib.
Absolutely. I'm consistently seeing that in practice as well. And I think we also have to keep the full picture of the patient in mind when we're educating and starting them on these drugs, because a CDK4/6 inhibitor may have been a surprise for them. Not every patient is kind of told about that up front. And some patients may see being presented with this option as kind of a stumbling block, while others might see it as more of like an opportunity to prevent recurrence. So I think if we can educate them on those side effects up front, knowing that they just finished chemotherapy, they probably had radiation, and they're probably looking forward to resuming some semblance of their life. Meanwhile, we're telling them, oh, now you're going to have significant diarrhea with abemaciclib, or you're going to have to come in for these repeated labs with ribociclib. If we can educate them early on how to manage some of these side effects, then we're probably going to get a better, buy-in from the patient as well. So what are some of those kind of management strategies that you see most effective for abemaciclib with the diarrhea, or anything with ribociclib that you think helps kind of get ahead of these things?
Yes, I'll start off actually with ribociclib on this one, and what we're commonly seeing, and won't be something that jumps out when you look at the actual numbers from the Natalie trial, but nausea and vomiting typically is something that our patients consistently will actually report to us. So that particular gastrointestinal toxicity, we always are going to send them home with some supportive care when it comes to nausea and vomiting. Of course, on the top of the list is neutropenia from our perspective, and we do have like preemptive conversations with patients about, of course, getting their labs drawn every 2 weeks for the first like 2 cycles, and as we establish that baseline of what their neutropenia is going to look like long term, we'll see if we need to employ things like dose reductions or even looking at growth factor, which is something that which was allowed in the trials, but it's also something that we use clinically across the board for patients on ribociclib and all CDK4/6 inhibitors. Honestly, in our clinical practice, setting the patient up to understand that that's a possibility, I find is always an easier conversation than not talking to them about the respective toxicity and then having to backtrack and have a conversation with them when they're having the actual adverse effect. It's always a tougher conversation because they're starting to wonder like why were they prompted for that when we first started the treatment. When talking about a abemaciclib, bowel regimen, of course, is always at the top of the list with diarrhea occurring almost up to 90% of the patients. That diarrhea with the loperamide being the major control mechanism for the diarrhea outside of dose reductions, always a key. Most of the diarrhea is showing up within the first 3 cycles of treatment. So within that first 3 months is where I always talk to patients about being in that zone to where we don't really know what dose the patient is going to be on. Is it going to be 150 milligrams twice a day? We're going to have to drop them down to 100 milligrams twice a day. All of those conversations happen up front to make sure we establish a very good baseline for what the patient is going to expect from the adverse effects. So yeah, with the abemaciclib, making sure the patient understands when we expect the diarrhea, what do we need to do as far as labs are concerned, because of course the neutropenia still could happen in up to 46% of patients. So it's not like it's not there compared to the ribociclib. May not be as pronounced, but certainly it's something that patients may have to get their dose adjusted, hold the dose. So all of those kind of toxicities, and I mentioned fatigue earlier as that kind of third wheel, if you will, as far as stopping patients from continuing treatment. And that's actually the big one. They always wondering like what kind of medication can we give? Of course, keeping their nutrition up, keeping their activity up. I always focus actually on exercise. I talk to patients about it. They have mobility to keep their exercise consistent, as that's one of those really effective things to combat fatigue outside of trying to address it with medications. And it truly is something that if they can control that, sometimes that's the main reason why patients will end up having to get out treatment because they are just consistently fatigued.
And I think we do have the benefit of these medications having been approved in the metastatic setting for some time. So we have plenty of experience with them. And it's really, as you stated, a matter of reviewing with patients what they can expect, how to contact us and reach out early if these things are happening so that we can get ahead of them rather than kind of chasing a side effect that's been happening for some time, and, kind of arming them with some of those things up front. Occasionally, we'll get to a point where a dosing reduction is kind of our next step. And some things to kind of review related to that in the monarchy trial, it was common for patients to require a dosing reduction, but less than 10% actually needed to discontinue despite this. And when we look at the Natalie trial, they actually dosed their initial dosing at 400 milligrams, which of course was less than the metastatic breast cancer 600 milligrams. And they extrapolated and justified this based on some metastatic breast cancer trials that showed that the response was similar at a reduced dose. So this was used as a strategy to lessen some of these side effects up front in this population. And when we look at the Monarchy and the Natalie trial, patients who required a dosing reduction and those that didn't, these patients still demonstrated a similar level of benefit to those who maintained that full dose. So I think it's also something to keep in mind that we want to help manage these side effects from a quality of life standpoint as early and effectively as possible, but it's not worth pushing the patient too hard to maintain these doses if we're not able to manage those side effects and have them end up discontinuing the drug rather than staying on it even at a reduced dose. So we want to try to maintain that dosing if we can, but we do still see that benefit regardless. And as I stated before, kind of keeping that full picture of the patient in mind. What are some of your thoughts related to that, or maybe some instances where patients were hesitant to reduce the dose?
Yeah, it's a great point, and as the data was released to show that maintaining efficacy was actually not directly related to the dose, it's always something that I try to come out of the gate talking to patients about when I initially give them their education on starting the CDK4/6 inhibitor. I like to open the lines of communication with myself and our clinical nursing staff to make sure the patient knows to report side effects to us so that we know when we need to hold the dose and possibly reduce the dose if the patient doesn't respond appropriately to the supportive care that we give. And the fact that the efficacy is maintained even though the dose is reduced, it causes patients, I feel like, to increase their communication with us as the clinical team, which can cause us to better treat the patient. So when I look at the conversations that are going on across the country about do you start a patient on a reduced dose initially and then progressively go up on the dose to see if that if you get a tolerable dose, like by escalating the dose versus the current FDA approved way to dose all of the CDK4/6 inhibitors to start with full dose, and then if you need to reduce, then you reduce the dose. But I can tell you that clinical practitioners across the country are sometimes starting at a reduced dose, which the Natalie trial highlighted the fact that that was being done at a rate to where they felt comfortable even starting the trial out at the middle dosing level, as opposed to the 600 milligrams, which was studied across the board in a metastatic setting, daily, 3 weeks on and 1 week off. So, my feelings are always, we evaluate the patient to see like what we clinically feel their tolerability is. And we will typically start at the 150 milligrams, but there are patients, like for instance, in the abemaciclib group, that we would actually start them at a reduced dose and see how they tolerate and progress the dose forward if needed. This is, once again, something kind of clinically see as appropriate and something that they are doing studies on. There is some data actually out there about starting at the reduced dose and seeing how it affects efficacy with no compelling differences with the dose reduction. The last thing I would kind of say specifically about this concept when we talk about the abemaciclib and the ribociclib is really talking about when you are so aggressive or rigid with your adherence to starting out to the letter with the trial. I feel like the patient is sometimes the one that actually ends up discontinuing therapy because they maybe have you've been too aggressive. So I do err on the side of talking to the patient about tolerability, dose escalation when I feel it's appropriate, and also just making sure once again that we open those lines of communication and we have this data behind us to really show that even though the doses are reduced, the continuation of the therapy at a lower dose shows that that's going to give you efficacy versus, of course, discontinuing the treatment is always our like last resort and what we would try to avoid at all costs.
Exactly. And I think you make a good point that we're still looking at the data that is being used and strategies that are being used in the metastatic setting to try and handle some of these side effects, like things like the dosing escalations and kind of how we can apply or extrapolate those to this setting as well, knowing that our goal here, of course, is recurrence risk benefit, and obviously hoping that that translates to reduced recurrence risk for distant recurrence as well. So a lot of benefit that we're potentially seeing related to this. And I'm excited to kind of review all of these things in more detail as we get to HOPA, and kind of dive even deeper into each of these topics. I think it'll be a really good discussion.
Thank you, Doctors Ziegengeist and Hunter, for joining us today. And many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Translating Evidence into Practice, pharmacist-led optimization of adjuvant CDK4/6 therapy in high-risk HR-positive, HER2-negative early breast cancer, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.